Regarding
This
long
conference
cases,
will now be recorded.
yeah, this is for the students who have not joined yet. So in the last OSCE in November 2000, in May 2019, these long cases were on the exam. Someone with a placenta previa, then another one having PET at 30 weeks gestation, then thyroid disease in pregnancy, and someone with bad reproductive history due to recurrent miscarriages, and a lady with previous 4 cesarean sections, planning another pregnancy, and declined tubal ligation. So as you can see that you must have seen these cases in your own wards also, in your own hospital also. So then regarding other cases, like they didn't ask last year, but what is your opinion? What other cases are admitted in the hospital? I'm asking about the obstetric cases. As you can see, all of these are OB cases.
Mhm.
Preterm labor, threatened preterm labor, twin pregnancy, then someone with uncontrolled blood sugar level, uncontrolled hypertension, someone who has developed a clot, so they will be admitted to the hospital. So, when you will go for the long case, they will just give you 2 sheets, blank sheets, and then you have to start from introduction. You will introduce yourself, and then you will take history from the patient, and you will record also. You can write in your shorthand, but you should not forget. Okay, the examiner is not going to read that, so you can write that, and then you can take permission from the patient, go to the right side of the patient, perform examination, and then again write down the findings. And by that time, the clinical examiner who is observing you will ask you that. Have you seen this case? What do you think what is her diagnosis? How you are going to manage her? So from there, everything will start. So you should not be confused at all. Go there confidently, take history, and now the problem is that examiner will be sitting there for all 25 minutes.
Mhm.
So it can be a bit stressful, but you should ignore him. Just pay focus on the patient, take a good history, and move on. So let's say you have started taking history from a patient and who had this venous thromboembolism. So ideally, what questions you should be asking in the history and what examination you should do. So you will take 2 minutes and then we will talk about it. Just organize your thoughts and then we will talk about that long case. Now, OSCE will also be related to VTE. So your time will start now. You can keep a copy pencil with you and just write down that what special points should be on the history.
It will be a like long history.
Yeah, long case. I'm starting with the long case. Okay, long cases today. First we will do OB cases, then we will do gynae cases. So just write down whatever you will like to ask her and what examination should be carried out, and then we will start with that case. Because the problem with the long case is that you will know nothing about the patient. You will go there, introduce yourself, take permission from her. Can I ask you questions? I'm here for the exam, and please tell me what is your good name and how many years of age you are, how old you are, and then the same points. Where do you live? What do you do for a living? How many children you have? All introduction, and you are going to write at the same time. Okay. Then why are you here? What happened? From where you were admitted? That is very important, because if she has been admitted from casualty, it means that she had some emergency condition. So that will be helpful for you, because once you will know that she has been admitted from A and E, you will think about some emergency, right? So then what happened? It will give you some clues. And after a history of presenting present illness, you will have a fair amount of idea that what exactly happened to her. That's why she is here. So after that, you will start recalling the facts and if she that what questions should be asked if she has VTE. So then you will start registering your own thoughts and you will register the information patient is giving you. So and then start with open-ended questions. Give her a chance. Tell me what happened, and she will go haphazardly. Like she will tell the last thing first, and the first thing she will mention in the end. But you have to put them in a chronological order. If she's going haphazardly, then don't erase or write up and down. Just number them. That this is the number one complaint, this is number two, and this is number three. So, and duration is very important. What happened, what they did. So, after that, if there are some gaps in the history, you will ask narrow-ended questions like the answer will be yes or no. So, finally, they diagnosed a clot. She will say, no, 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 there was no clot, but they just suspected that. So then you will go to other points of the history. Then you will take permission from her and then she can examine you. Do you know what was your blood pressure this morning? So she will tell you, okay, because you won't have this BP apparatus with you. So you will just ask her and just do general physical examination, move on, do local examination and examine her tummy, record your findings. And you know, these patients, during history taking, they will tell you that, Doc, I came to the ER, I had a swollen head, painful leg. They gave me some shots. First, they ran some drip, and then they gave me other shots in the skin. And then they told me I was reviewed that I should be reviewed by by the doctor who deals with patients in with such conditions. So after that, he advised to do that, and then I'm sitting here. So you can summarize in the history. So you are so and so. You develop this complaint, and now this much has been done, and you are waiting for that thing to be done. Okay, that's how you would summarize. So that if there is some mistakes or some information, this patient will let you know about that, and then you will present the history to the examiner. Okay. So now just make a mental plan that what
But
should
like
be
it will
asked.
be in the lay language.
Yeah, yeah, yeah. Lay language and no medical jargon. But when you are presenting history for the examiner, you can tell that this was done. History, whatever the patient is telling you, okay? No medical jargon, but you can use words like that she was reviewed by hematologist who started her on low molecular weight heparin, okay? And when you're talking to the patient, she will say that I was given blood thinners. And sometimes, if their education background is good, they will be knowing about the name of the drug also. But it doesn't matter. Just say that she was starting on medicine, she has been receiving treatment like that. So, VT, you know that if she would have been admitted from the ER because she suffered from something. Then you can find patients who have been admitted from the clinics, like they came to clinic for something and then like their sugar level was found to be very high, so the clinician advised admission for improving control of blood sugar. So place of admission is also very important. So because it will be very helpful in planning her management. So that's good. Okay. So you have to mention all of these points. Okay. Then don't worry. Once you will tell me the questions, then we will go over the case. That what is the right thing to do? Is anything missing here in the information or not? So long cases as such, they should not be difficult because you are supposed to take a history, do targeted examination, no intimate examination, and these patients they will tell you that what investigations have been done so far. They will tell you that they took my blood this morning and also urine sample. So you can say that this much has been done. So you are choosing the information that patient has given you. So after that, the examiner will ask you, what is your impression? So you will tell about the provisional diagnosis, differential diagnosis in some conditions. So then he will continue asking you several questions. Okay. So, and these questions, they will not be of very advanced level or very complicated questions because, you know, in Irish medical practice, they can take this MRCPI after 2 years of training. So you can say that it is like the IMM when you're doing this FCPS. Okay, so it should not be that hard. Okay, so if you have a patient with VTE, then how we should manage her? Then how?
But
What are
uh, but like
like?
I'm talking to the patient now, or I'm talking to the examiner?
No, no, no. You will talk to the examiner. Just make
Examiner,
a
okay.
this is interactive discussion. Like when you will start taking history, you know nothing. Okay, but then once the patient tells you that I was admitted because I developed a clot on my leg. Okay, so then you will know that this is a case of VTE. So you should ask that did they confirm diagnosis? She will say yes. So then you will continue. What happened? What was done? What was given? So you just register your points in 2 minutes, and then I will show you the screen that what should be asked in the history, and how you have to present all this case to your examiner. This is just like practicing, like a workshop. We are just discussing that what should be asked, and how we can gather more information, and how we will present it to the examiner.
Okay.
So you can take like 2 minutes to organize, and then we will talk about that.
This conference will now be recorded.
So can we talk about that? That if you
Yes.
have with venous
Yeah.
thromboembolism, so ideally, what should be in the history?
Yeah. Hello,
How
I'm
you?
Dr. Faria. I'm one of the exam candidate, and I have taken the history. This patient is, I will ask the patient, first of all, I will introduce myself to the patient. I will do hand hygiene, and then I introduce myself to the patient, and then I will tell her that I am here for the examination. And usually we will be asking or examining in presence of chaperone, but here I am in the examination. So I will take her history. I may like to do examination with her consent, and then I will advise some investigations and discuss management options.
Yeah,
And so then I will ask the patient full name, and then I will ask her that where she is living, her address. And because sometimes we have to write the letter to the GP, or we have to call back the patient, so we should know the address. Then I will ask the patient that what she is doing for living, like what is her education, so that I can understand that she can understand me well. And then I will ask her that if it is like sometimes we are asking ethnicity in some cases, and then I will briefly ask her that how many gravida and cara she is, any history
yeah,
of miscarriages and ectopic pregnancy. It will be just a brief when I am asking the biodata. And then I will ask her that from where, that what was the problem she was admitted, and whether she was admitted from the emergency, or whether she came to the through the ward or a clinic. And then I will ask her that what was her complaint. She If she is telling me about the swelling and tenderness in the lower leg, then I will ask her that since when it started. And I will ask her that how severe is the pain, and how it is affecting her life, and whether she can walk with it or no. And there are any other associated signs and symptoms, like there is redness in the leg, and there are any varicose veins in the same area. And there is also associated symptoms, like if she has any difficulty in breathing, if she has any headaches, if she has any other pain in any other part of the body, whether she has any coughing up of any blood, any chest pain, and whether she feel like fainting or collapsing, and also like if she has difficulty in breathing. And sometimes because the DVT can involve other parts, so I will ask her if she has swelling in any other part of the body. Then I will ask her that uh, uh, what like if she is recently, like she has been admitted before, then I will ask her whether any tests have been done and whether she knows about that what they are suspecting. But if
Yeah.
she has come just in emergency, then I will ask her about her, if she is pregnant, then I will ask her about her pregnancy, that how is the pregnancy been so far, whether she has been, it is a planned pregnancy or it is like spontaneous or IVF, because IVF pregnancy may be associated with complications. Then also I will ask her whether she has been having vomiting during the pregnancy, because dehydration is one of the cause of DVT. And then also I will ask her whether she had any history of any I will ask the routine history like dating scan, about the dating scan, whether she had the Down syndrome screening, about the anomaly scan, then any serial growth scans. And also I will ask her history, like if she has any problem during the pregnancy, like being threatened, there had been bleeding in the pregnancy, and whether she has any gestational diabetes. It will depend on the gestation of the pregnancy, gestational diabetes, any preeclampsia. And also I will ask her about any history of any infection, like maybe she has any infection during the pregnancy, like urinary tract infection. She had been, she was not mobile during the any time of the pregnancy. She had any admission during the pregnancy. Then I will ask her that whether she had any history of like sometimes maybe she had any surgery like appendectomy or any admission during the pregnancy. And also I will ask her that uh, this how is the baby moving, what is her blood group, what medication she's taking. Then going to the previous history, it's very important to ask about the previous history of venous thromboembolism, whether she had any episode during in the past, whether it was pregnancy related or whether it was related to any contraception she was taking, or whether it was unprovoked, related to any surgery, minor surgery or major surgery. And also this one, I will ask about her previous deliveries, previous pregnancies, because maybe she had any history of DVT or P in the previous pregnancies. Then I will also ask her that whether she has history of any travel, uh, like more than 4 hour travel anytime during the pregnancy or recently. Then also I will ask her that but if she has a previous history, then I have to take in detail that what was it, what was it diagnosed as VTE, and whether she was taking any blood thinning agents for that, and what investigations were done. Because I want to establish that it was diagnosed or it was just suspected.
Yeah.
Then also I have to ask whether, because her family history is also very important, because there can be family history of VT in one of the family members. So I have to ask about that in detail. Then regarding
Yeah.
the medical history, it's very important to ask about any history of any medical problem, like there can like these diabetes, hypertension, then sickle cell anemia, inflammatory bowel disease, then any renal disease, any autoimmune disease, antiphospholipid syndrome, and SLE. Then I also have to ask about this one, inflammatory bowel disease, ulcerative colitis, then Crohn's disease, rheumatoid arthritis. And also I have to ask her about this one, any surgeries in the past, and maybe there was any episode of VT during the surgery, or any prolonged surgery. And then I have to ask her any history of any trauma, accident, that she may be using wheelchair or any other state of immobility she had ever. Then in medications, I have to ask her what medication she's taking. Maybe she's on aspirin. She is a high risk case for preeclampsia. Then she may be taking aspirin, and whether she's taking any blood thinning agents now or no. Also, we have to rule out cardiac valvular conditions in the medical history, because maybe she's taking already some warfarin or low molecular weight heparin. Then in the personal history, it's very important to ask about her support and support whom she is living with, because if she's having DVT, she may need prolonged hospitalization and she may need some prolonged treatment, so she needs partner and family support. Then in personal habits, I have to ask about smoking, alcohol, and recreational drugs, because and also IV drug abuse, because that is one of the cause of venous thromboembolism. And I have to ask about any drug allergies, because she will be given medicines. So I have to ask about heparin allergy, drug allergies, and also maybe she may need blood transfusion. So I have to ask about concerns about blood transfusion as well. Then also a little bit I have to ask about the lifestyle, that she has a sedentary lifestyle, or she is physically active, she is doing some exercise, she's doing gym, and she's taking healthy diet. And so this I have to ask her. Then I have to examine her. I will then thank her for sharing the information, and then I will ask her that whether she want to add anything. Then I will summarize the case, and then I will examine her. I will tell her that I will examine her in the presence of chaperone with her consent. And but that's, as this is examination, so examiner is here, and if she is it okay for her to continue examination. If she agrees, then I will do hand hygiene. I will put her in proper position. I will tell her to lie down supine with the knees flexed, and I will cover her. I will maintain her dignity, and then I will stand on the right side of the patient, and I will take her blood pressure, pulse, respiratory rate, temperature, oxygen saturation, and then I will do a head to toe examination to look at pallor, jaundice, any signs of dehydration, and also I will look at her thyroid. I will ask her, I will just have a look in her oral cavity to check her oral hygiene. And also I will ask her to swallow, so I can check her thyroid. This one I will do when she was sitting before, so I will ask her to swallow so I can check any thyroid swelling. Then I will examine her chest. I will auscultate and see any added sounds, and I will check her heart sounds, whether they are normal or there is any added sounds. And then I will check her tummy. I will check her fundal height, and if possible, I can do. I will examine her like superficial palpation inspection, superficial palpation, then deep palpation for visceromegaly, and then I will do the fundal height for how much she is pregnant and how the baby is growing, to rule out any IUGR or any other. And then I will check the fetal heart of the baby, lie, presentation, and then I will check hernial orifices, any scars on the tummy. If there is a scar, then I will see whether it is vertical, it is transverse, and there is any herniation of the scar or any keloid formation, and any if previous cesarean, I will check for scar tenderness. And then I will examine her legs. I will do the venous thrombosis risk assessment as well, and then I will check the local examination for the DVT, where she is saying that there is red and swollen hot leg. And then I will check which part of the leg, it is lower or upper. And then I will do the girth of the part. I will take the circumference, that how much is the difference between the right and the left leg. I will see with my hand. I will check the local temperature, whether it is hot, and also any tenderness at that part. Before we used to do the Homan sign, but nowadays it is not recommended to do it, because sometimes they say the clot may travel to the lungs. So we can just ask her whether she is tender in that area, and then
Yeah.
I will ask her to give a urine sample. I will like to check proteins, because maybe she has, and I will check her blood pressure already checked. So I will take a urine sample for protein and ketones, because dehydration and proteinuria or preeclampsia. These are one of the causes of DVT. And then I will then like to do some investigations for her. I will tell her that we are suspecting uh, a problem that can be associated, that there is in pregnancy already there is a hypercoagulation, like there is a state in which there is a risk of blood clotting. And we are suspecting that there is some swelling in your leg, which can be a serious life threatening condition. And what happens is that there is there may be a risk of clot formation in one of your vessels in the leg. So usually, if it is confirmed, then we have to treat you, and your stay may be little longer. So but we need to do some tests, and need to involve some multidisciplinary team, which will include consultant and the blood doctor, and doctors who do ultrasound and X-rays. And also I will offer you specialist midwife, and they will take care of you, and they will do some additional investigations test, so that we can know that whether it is just swelling, which can be some due to infection like cellulitis, or is it a venous thrombosis, which is a serious condition in which there is a clot, and if not treated, then it can travel to other parts of the body, especially lungs and heart, and it can be life threatening. So then I will offer her blood test, which will include full blood. First of all, if she is in pain, I will offer her painkiller, and then I will tell her that if it is okay to continue, then I will offer her full blood count, then blood coagulation profile, which will include prothrombin time, APTT, INR, fibrinogen, and then I will tell her that we need D-dimers. D-dimer is not very specific in pregnancy, so not important. And then I will tell her that we will offer her a special ultrasound, which is called Doppler duplex compression ultrasound for both the legs. And if we which will look at the clot in the vessels. I will tell her that if we have high suspicion of DVT, then I will start her on this one on blood thinning
Treatment.
agents. I will explain to her that these are blood thinning agents, usually safe, but in the long term, then they can cause some osteopenia and thrombocytopenia. But the risk is quite low with this new type of blood thinning agent, which are called low molecular weight heparin. So then I will offer her according to the body weight at the booking of the at the start of the pregnancy. That was at the booking visit. And I will tell her that these are usually, we will teach her how to inject under the skin. And also I will tell her that we will tell you about the safe disposal of the needles and the syringes. And then according to the body weight, we will tell her that if there is a strong suspicion, the multidisciplinary team will like to start the injections, and then and side by side they will continue the investigations. If the Doppler ultrasound becomes positive, then she will be given this treatment for at least 3 months. 3 months, continue for 3 months. And if the Doppler ultrasound becomes negative, then and there is a strong suspicion, then she will be offered other investigations. We will repeat the Doppler after 3 days, and 3 and 7 days, and we will offer her and then we also would like to do some if she has any signs of breathlessness or any other problem, then we will offer her chest x-ray, ECG, arterial blood gases. And if these are negative, then fine, she will be and there is no suspicion, then the treatment will be stopped. But if high degree of suspicion, then she will be continued on the treatment, and this they will be test will be repeated again after 3 and 7 days. And anything
Yeah,
you want to ask, Dr. Aisha?
yeah. When you will tell this much, then they will ask
Yeah.
you that you will tell about the treatment. Once you will present history, everything. So, like I said before, that we will the trick of the long cases and the short cases on the OSCE is that we will focus on the same case, the one we have. Okay, so you have mentioned beautifully everything, which is very important. So they will be very happy to listen to such a detailed history and examination findings. So then, they will have to ask you certain questions. For the history, you are going to describe what the patient has told you, okay? And if she has any gaps in the history, then you are going to ask relevant questions. That's why I asked you what
We have
questions
to
should be.
tell history and examination, and then we have to stop.
Yeah, so then you will stop, and then you also need to say another thing, like we talked about it yesterday also, that when you are presenting the history, then you will start like, here I have Mrs. So and so, who is how many dash years old, lady from which area, an engineer who is gravida para at how many weeks gestation, admitted from for investigations of suspected DVT, all presenting complaints in a chronological order. Then you will take history of present illness. So then you will say she was admitted from ER or from the OPD, and because she presented with complaints of an erythematous swollen and tender lower left limb. This was
Hmm.
confirmed on examination, where the left calf diameter was, there should be a difference of at least 3 centimeter between two diameters greater than that of the right. So she will tell you, this patient would have been instructed to tell you that there was difference in the leg size by 4 centimeter by 8 centimeters. So anything she will say, you will write that down, because during this exam, since she has been admitted and the diagnosis is there, so you don't have to measure her legs. Okay, so
Hmm.
no need to waste your time like 30-40 seconds. And then she was commenced on therapeutic low molecular weight heparin while venous doctor
But it
was
will
pending.
be somewhere written examination.
uh, it will not be written anywhere, only you are going to write on your two sheets, like when they will take you
No,
to
no,
the
I
room of.
mean we will have some findings from before.
No, 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 nothing.
No,
Just two
nothing.
blank, nothing at all. So this patient will tell you that they admitted me 3 days ago. Then next day they did some scanning, they did ultrasound. So that's why you will say next day she was scanned and this diagnosis was confirmed or not. And sometimes these patients, they will tell you that now they are planning to do so 1, 2, 3 for me, and then you will say that she is waiting for that thing. Okay, this is how you should present to the examiner,
No,
and
no,
then she
I
will
mean
tell
like
you.
you said that no need of examination. So how I will know that the examination
No, no,
has
no,
been
no,
done?
you will do the examination, but I told you that if she has been admitted with a diagnosis of DVT,
Hmm.
you will take history. You will go to the examination and you will look at her legs. Okay. But
Okay.
since, she has already been diagnosed and she has told you in the history that on my admission they measured my legs and there was a difference and my left leg was 4 centimeter bigger than the right one. So
Okay,
just
okay.
mention that one. Okay, because you're not going to diagnose her. It is a diagnosed case, and she is admitted under some ICD code, international, this
Yeah, yeah. I see
this
10.
of the disease. ICD-10 is what they are following now. So she already has been assigned a diagnosis. Okay, so you will,
Hmm.
when we will go to the examination, like, we will observe her legs, but you don't have to take the size again. That's what I
Okay.
said. You will have nothing would be written there, no screen and nothing. It will be just like an old room, and one bed will be there. Patient will have some belongings. They will give you one chair, and they will give you two papers. Okay, and you will have, sometimes there will be some table or any small teapot, etc., where you can put your tables and you can write down. If they have nothing, just put those papers on your lap and start writing. They will give you pencil. And now the examiner is also there, so most likely examiner will be sitting across the bed of the patient, okay? And they will just observe that how you are talking to the patient, how you are taking history, and he will have his own sheet where he will be checking boxes, okay? So as far as you are concerned, you will have only two blank sheets with the name of the hospital, hospital logo will be there, and nothing else will be there. So you have to start from the baseline. So what I said was that if she's telling you that one leg was larger than the other one, then you'll say that one leg was 4 centimeters. She says that one leg was bigger than the other one. So don't take measurements during history or even during examination. No need to waste time, okay? Because she has. But when we will go to the examination, then we will talk that what should be examined. Okay. So any confusion, Dr. Freya?
No, no. Yeah, now I understand. I thought no need. It will be written there.
Yeah.
Like there is no
Yeah,
scenario
so
written
nothing will
and
be
we
written
have
there,
to, okay.
just blank pages. Why I said mention this point? Because if you get up at this point and you take her sizes, they will say that she didn't go in a stepwise manner, she didn't complete history and just jumped to the examination. While that is not the case, reflexly, what happens when we are going for the ward rounds, if patient will tell something, some new complaint, then what do? We just try to check for that, right? That is our reflex. So for the exam sake, we just have to sit there comfortably and record all the everything the patient is telling you. Okay? So when we will go to the examination section, then we will talk about it.
Okay.
So then you should say that she was, and this finding was confirmed on physical examination. And when the diameter of one calf was this centimeter greater than that of the right leg. She was commenced on low dose low molecular weight heparin. She will tell you the dose also. And while venous Doppler was pending, or it was done, or the finding of DVT was confirmed, or venous Doppler, whatever would have been done for that, she is going to share that with you. And then you should say that she is currently undergoing low molecular weight heparin administration education, that how she should give it under the skin, and about receiving counseling on safe disposal of the needles. And it will be she will be followed up in the medical clinic with the hematology consultant. So she has been here for this many days, and daily CTGs were done and they have been normal. And she reports good or reduced fetal movements as she will tell you, and no history of dyspnea, chest pain, or any palpation. So then you can say that actually in her history, as we can see, she these are the risk factors. These should be in your mind because the examiner will discuss these with you. So you will not take time separately to find the risk factors. Okay. So you can say that she is this many years of age with a BMI of this one, no recent immobility or surgical procedure. She has a history of hyperemesis recently requiring admission for dehydration or in the past. And this is her first episode of VTE, and she has no family history or she has a family history of VTE, whatever will be the case. Okay? And she has no other medical history or she has some medical history. So once you will start asking her about the past illnesses, you should not say that yeah, IBD and everything. You should say she doesn't have any chronic illness, no
Any
connective
chronically.
tissue disorder, no immunological disorder. That's how you're going to save your time. Okay. Then you should say a couple of things about the current pregnancy. This was an unplanned or a planned pregnancy, spontaneous conception, booked for antenatal care at this many weeks, had a dating scan at dash weeks, 9 weeks. She was confirmed, which confirmed the estimated date of delivery by LMP at mentioned that. Her antenatal course was previously complicated by hyperemesis requiring 3 admissions, or if there was something, maybe there will be nothing, but this is just a pattern, just a sample, and it will be changed according to the history of your respective case. She had normal working blood test and serology, her blood group is so and so, and she had an anomaly scan ultrasound at 21 weeks, which showed no abnormalities and an upper placenta and appropriately grown fetus. She attended combined antenatal appointments if she had any medical disorder. If she had nothing, she just attended her routine care. Regarding her past medical, surgical gynae history, no background medical or surgical history of note, no significant gynecological history with menarche at age 12, normal menstrual cycles, and cervical smears, which have always been normal and up to date, and she previously used the COCPs for 5 years.
5 years.
Then the question arises, is she on some medicines? Right now, she is, this part is important because the examiner will ask you. So you should say that she is receiving these medicines, okay? And the doses are not important, but you should know that your patient is on these drugs. Maybe she's on iron at the same time, folic acid, some painkillers. So whatever she is taking, just mention them. Then at the same time, whenever you are mentioning medicines, you should say that no known drug allergies, very important patient safety issue. Rather, MRCPI has always been testing patient safety issues, communication, and applied clinical knowledge. They are writing in their in their this handbook, and RCOG has introduced these concepts like 10 years after the RCPI. So important drug is patient safety issue that she has no allergies. Obstetric and the previous pregnancies, if there was any problem, if she had any previous pregnancies, then you should say that she has 3 kids aged this and normal pregnancies, and then without any complications, deliveries were normal and the birth weights were average. And don't say anything which you have not asked the patient, because examiner can point out that you didn't ask this question and then you are saying that you have asked. Okay, so you have to be very honest. You are going to be fine. Okay, it is just like a routine. When you do go for grand round, then your juniors must be taking history, but here you are going to do that yourself. So then what were the modes of delivery? Are the children fine now? Then any family history? No significant family history, no family history of VTE. She is a social smoker or non-smoker. She is a social drinker and she is not taking any drugs. She lives with her husband. And then who is caring for her children if she has other children? And occupation we asked in the start, but if you like, you can say here also, because maybe she has a sedentary way of life. Okay. So once you have taken for describe full history, the examiner may tend to forget, but you have to present your case, right? So you will say, so I will summarize the whole history for you now, announce like this, okay, and to draw his attention, and then say, right now we have Mrs. Helen, who is a 27-year-old Caucasian woman at 32 weeks gestation in her third pregnancy and has been admitted with a deep venous thrombosis. She has been commenced on low molecular weight heparin and she will be discharged with follow-up in the medical clinic under the care of maternal medicine and hematology. So again, summarize the history. It will leave a very good impression on the examiner. My experience is that those candidates who took a detailed history and they followed this pattern, they summarize in the end, they all passed their OSCE in the first round. So there were other students who were very good. They had excellent clinical knowledge and everything, but they failed because they couldn't present their long case appropriately. So no benefit, right? So you have that's why I'm telling you that these long cases will start at like 2 p.m., 3 p.m. Okay, so you need to stay fresh. And the trick is that you should sleep well. If you need to take some tab or you need to eat something, decrease your intake of coffee, sleep well, get up fresh in the morning, okay, and then go to for the examination. In the examination hall, no need to take any book with you. um,
This
no,
Caucasian, how we can ask, like Caucasian, she will tell Caucasian or
no, she will not tell. You will see that she is a fair complexion patient and
fair
she is living
complexion.
in born and brought up here. And if you will see that she is belonging to some other ethnic group, then you can ask her. If you don't mind, can you tell me about your ethnic background? Because some conditions are more common in certain ethnic groups. Okay, that's how you're going to ask, because we are not biased against anyone, right? That is the point. Because if she is of Mediterranean origin, you have to think about hemoglobinopathies. If she is from the Gulf, then you have to think about GDM, right? And also VTE, because of higher BMI, more complications. Don't worry about that. These are recognized patterns and these are recognized questions. Okay, so and you need to tell the patient that some disorders are more common in certain ethnic groups, like that. So then you will take permission from her. Go and stand on the right side of the patient. Demonstrate hand hygiene. So if they don't let you take this, this sanitizer, usually they will allow you, but if they don't, then don't insist. Just say that I like to wash my hands before I proceed. It will take 30 seconds. Just go and wash your, this hands. Take some tissue papers with you, okay, so that you can clean your hands later. So I remember I was taking this USMLE clinical skill and they had 12 cases and I had to wash my hands 12 times because they have, these sinks in the room. And every time I washed my hands and I took tissue papers from there. So you are taking just one case, so you can also do that. Don't worry about that. If they let you take the sanitizer, that's fine. No issues with that. So then you will stand on the right side of the patient. This is important because I have seen doctors doing examination from the left side, which is not recommended. Okay? Go to the right side. Okay. So then examine her, and then at the same time you can ask her that did they maintain meal chart for you? They know about the chart. Did they maintain your vital sign chart? She will say yes. So then she will say that is are there signs of anemia, tachycardia, cyanosis. what is the BMI, or you can ask her also, did they tell you, can you please tell me about your BMI? They will have some idea about that. Look at her hands, palmar trees, pallor. Is there any phalonychia? Examine her eyes, look for any pallor. Then auscultate chest. Put your stethoscope on the left side, and then you can say S1 plus S2 are audible. Then go to the right side of the chest, and you will say that the respiratory sounds are audible. Then, with permission from the patient, can we have a look at your tummy? So I will maintain your dignity. Okay. She will say yes, no problem. So you will do inspection. Then you will say that abdomen is distended consistent with this many weeks gestation. Obvious cutaneous signs of pregnancy if you have like minion plus certain trigravidarian. Then you can say that can I feel can I examine you like this. Before you were just visualizing. So ask about if she has any pain, and when you are palpating her tummy, once you have taken this fundal height, then you will do palpation. Palpation can be done during pregnancy also. Okay? Put your hands to the sides, and then don't look at her tummy. Look at the face of the patient. You have to demonstrate that you know what exactly you are doing. So no tenderness, no rebound tenderness, what is the symphysiofundal level, and then uterine palpation, where is the fundus, lie, side of the breast, and you will get some idea about the liquor also, because if it is disseminated, the liquor is going to be fine. The presentation, if you can find, if you cannot determine presentation, no need to comment on that. Engagement you are not going to see, but you can see in the exam. Just put your thumb and the fingers on the lower part of the tummy and say the head is not engaged. Okay, if he's not in labor, of course he is not in labor, that's why she's there on the examination. Look at you can find if you have this stethoscope, you can find the beaten heart. If you can listen to that, that's good. If you cannot, or you are running short of time, just ask the patient for fetal movements. Okay, that's fine. But just if you can put the bell of step on her tummy, that will be fine. So cephalic presentation, just put near like this. And if it is breech presentation, then you have to put your stethoscope above umbilicus. So look at the legs for the evidence of DVT, because if she has really experienced DVT, so still maybe she will have cellulitis. And then we can mention that she is wearing flat stockings or she is not wearing. With that, you will complete your history and examination. Then they
So
will
then
start.
the examiner will ask the questions.
Yes. The first
So I
question
don't
will
need to mention investigations,
no,
like no
no.
need.
Your task is, to take a good history, do examination, ask her about the treatment she has received so far. And usually, these patients, they will tell you when you are writing this history, they will tell you that they have given me these things. Okay. So what you should do is on the page one, start writing the history. Page two, like the back side of this paper, write down her examination findings, because she will tell you. Then you have another sheet. On that, write down MGT, management. So write down that she has received these things so far.
Okay.
They are best because you are not making a mixture of the history, you are giving a clear cut history. Okay. So the better sequence between history, examination, treatment done so far, and what is your further plan. So, but we cannot tell the patient that tell me about the treatment after once I examine you, then you should tell me about the treatment you have received. So the wiser thing is that you already divide your two papers into things. First one history, back of that one examination, and any management she will tell you, write down on the separate sheet, so that you will know that what she has received so far and what you should do next for her. So you will not have, then by doing like this, you will not have to explore your search your history again, and you will be giving history in a smoother way. So that's how I did, and it was very helpful. So then they will ask you, what is your impression? What is the diagnosis? So you will say 27-year-old, they have done this paralysis this many weeks with left leg DVT. So then you will start with the Viva, and the Viva questions are not hard. You will be knowing all of them. Then you tell me about different risk factors for PE. Go for the common ones. Age more than 35, immobility, obesity, family more than 4. operative delivery, dehydration, like it can be due to, like you said before, hyperemesis, it can be due to long haul flight and like more than 4 hours. Then hemoconcentration, like in cases of PET, ovarian hyperstimulation syndrome, if he just had some surgical procedures, previous VTE, excessive blood loss, anemia is also a risk factor. Sickle cell disease, IBD, any infections, congenital thrombophilias. And you should remember that congenital thrombo or hereditary thrombophilias, they count for very low percentage of cases of VTE. And the acquired ones, they are more significant. Among the acquired ones, this one, factor 5
And
Leiden
if
mutation, that is the most common thrombophilia acquired during pregnancy. And then you can say that in pregnancy there will be deficiency of protein C and protein S. Basically, protein S will be very low, so less production of APC.
the Dr. Asha,
Okay.
this factor 5 is not congenital. It is
Can be congenital, but can be acquired also.
acquired
So,
also because this antiphospholipid syndrome and
yeah,
this is the acquired one, the thrombophilia.
yeah, these are acquired ones. So, among the hereditary thrombophilias, the most significant and lethal one is antithrombin 3 deficiency. That is
Hmm.
the the most common thrombophilia, acquired thrombophilia. Okay, and if they will ask you about the most commonly acquired thrombophilia during pregnancy, that is factor 5 Leiden mutation. It can occur. Maybe it was latent, but due to the changes in the pregnancy, it has become apparent. Can be hereditary, but most commonly acquired during pregnancy. Then, you know, most commonly diagnosed during pregnancy. These are hereditary thrombophilia. Anti-glucose anticoagulant, anticardiolipin antibodies like antiphospholipid syndrome, you will say that this is acquired during pregnancy. This one, 55 Latin mutation, that is hereditary but most commonly diagnosed. That
During
should be
pregnancy.
most commonly diagnosed thrombophilia during pregnancy is factor 5 Latin mutation. So then they can ask you which one is more dangerous, homophilia, homozygosity, or the heterozygous. So which one is more serious, heterozygous or the homozygous? One is 5 times more common, and one is 30. Homozygous is like 5 times more common. Heterozygous is like 35 times more common. But they will ask you that which one is more the least serious one. Antithrombin. Why this is the most lethal one? Because if it will occur, it will be very severe, and then you will have to give her antenatally low molecular weight heparin and also postnatally for 6 weeks, not for 10 days, 6 weeks. So then you should talk about the investigations. You can divide that first line investigations like full blood count, C-reactive protein, not specific, but it will give you some idea that inflammatory process is going on. We will go through the urea and electrolyte, LFTs, coagulation profile, and low molecular weight heparin. So, urea and electrolyte, all of these investigations are necessary before starting any treatment. So if patient has respiratory symptoms, then you should go for arterial blood gases. And it will give you information that there is hypoxia or there is alkalosis. ECG should be done, and if it is positive, it will show. They will ask you what will you get on ECG. If negative, okay, that's fine. But if it is positive, so you will see sinus tachycardia. There can be right bundle clot, or there can be changes. If they ask you that what changes, then you can say S1, T3, and T3. There can be changes. Chest X-ray. 50% patients they will have a normal chest X-ray, and this is job of the physician. See what exactly is there. If they will not ask you, then you will have to offer objective tests. They are specific for them, like compassion duplex ultrasound, and then if you will see the chest X-ray. If chest X-ray is normal, your next investigation will be ventilation perfusion scan. In pregnancy, usually we will only ventilation, we will not do perfusion scan, only ventilation. If chest X-ray is abnormal, then you will go for CTPA. This is here. If you will do VQ scan, they will ask you what is the side effect, what can happen to the mother or the baby. So you can say that evidence shows that the chance of having childhood cancers will increase. If you will do CTPA, you will say that it is safe for the baby and it will increase risk of having breast cancer for 6 months. And fetus will have very poor
This one,
radiation.
can you repeat, Dr. Aisha? The chest X-ray is normal, then we will do the
Yeah,
uh,
chest X-ray
or
is normal.
abnormal. Chest
Is
X-ray is
normal.
abnormal, then we do CTPA.
Yeah, normal.
If
Okay.
normal, then ventilation scan.
Yeah, and if it is abnormal, then you will have to go to the
We'll do the
specific
CTPA.
to see that artery or vein to see that what exactly is happening. Okay, so if you we will do CTPA, it will increase mother's risk of developing breast cancer. So then they will ask you that how do we manage VTE? So initial treatment is with no molecular weight heparins. So we don't have to take all patients with DVT to the high dependency unit. They can be managed on the ward with the help of a multidisciplinary team. Start IMU's chart. Why? Because your patient can develop respiratory complaints at any time. So all serious patients like the one with PET, someone with a hemorrhage, someone with sepsis, you should start IMU's chart. So initial treatment with low molecular weight heparin. Why low molecular weight heparin? Because if we will give it subcutaneously, bioavailability will increase. More drug will go into the system. But the basic advantage is it has longer plasma half-life. So we can give once daily administration. So easier administration than unfractionated heparin. And while you are getting the same effects, same benefits. So duration of treatment, so she should at least she should get 3 months of therapy, and usually if it is in the early part of the pregnancy, then she will have to continue taking it maybe for 6 months, 3 months, and then 6 weeks postnatally. It depends that when it is diagnosed, and if it is diagnosed in the later part of the pregnancy, then she should complete like 3 months of therapy. So if it is in the early pregnancy, so reduced to initially she suffered this VTE, but then she was fine. So you need to reduce to prophylactic dose once the therapeutic regime has been completed. But you will say that you will just inform the patient, but this dose will be prescribed by the hematologist. Then they will ask you, uh, so how you will provide further management. Consultant
Yeah, we will like
therapy.
educate the patient that she has to
Yeah,
stop when she is
the
going in labor.
yeah, that's
Yeah,
very
if she
good.
develops signs and symptoms of labor.
Signs and symptoms
So
of labor.
therapeutic at least 24 hours before, and this one prophylactic at least 12 hours before.
Yes. And if she is going to she's going for induction of labor, then she should take this prophylactic day one day before the induction planned date of induction of labor, and also for the this one for the cesarean section also she will take the dose on in the evening, and then she can stop because then she can take post operatively on the same day. They are very keen to ask about this thing, that when should be the
Yeah,
given
this
when
one more
is
than
the
4 hours. Yeah,
more than 4 hours should be there. And then if you are giving and don't remove the epidural catheter until 12
till
hours
12
after
hours
last.
after that those days.
So
And also,
that's
I
all
think
you
if she is high risk, then they can give her unfractionated heparin like
unfractionated
4 hours
heparin.
before or 4 hours after the surgery.
Yeah, because that has a shorter half-life. Okay, that's very good that you remember that point. Because if the patient's risk is very high, then we will never stop it and we will give it to her. And 4 hours after the CS again, you can give her unfractionated heparin. Then they can ask
And
you,
also, we have to. She may ask that they may ask that does it affect the baby? So it does not cross the placenta, and therefore it
yeah,
does not harm the baby.
yes, it's a
So
large
she
molecule.
can breastfeed. Yeah, she can breastfeed safely.
Yeah. So after that, after once your patient has delivered, then you will get her reviewed again, and maybe she will have to go back if she was taking warfarin from the start. You can say that in under they can ask you that is the just heparin the only blood thinner available, or you can tell me about other blood thinners? You can say that there are many other blood thinners, but we have more experience and more data on patients' safety if we will give low molecular weight heparin during pregnancy. So that's why we gave it to the patient. What are the risks if you will give low molecular weight heparin?
Usually the
Thrombocytopenia.
patient, like in a short term, patient will have bruises, but in the long term, she can have thrombocytopenia or osteopenia.
Osteoporosis, yeah. So I was going towards that. If she's having a cesarean delivery, the chance of having a wound hematoma 2%. It is the same with both unfractionated heparin and low molecular weight heparin. Then about the
And
long term,
sometimes allergic reaction, I think very low risk.
yes, allergic reaction. But if you remember, you should say that because they will give you extra credit for that. And then what else you should tell them that once the patient has received all of these treatments, then she can be started back on warfarin. So they will ask you that warfarin, can it be taken safely while she is breastfeeding? You will say yes, it can be taken
Yes, it
safely.
can be taken.
And then you should say that we should not stop low molecular weight heparin abruptly. Both drugs should
At
be
least.
heparin and warfarin should be continued for 3 to 5 days, and then after that we can remove this one.
Yeah,
You
we
will
can
remove
stop.
this
Yeah,
molecular weight
overlap will
heparin
be for 4 to 5 days, and then we can stop heparin and then keep her
like
on
that.
warfarin. But on warfarin, we have to monitor her INR like
INR.
frequently, so that
They can ask you if patient has some high risk condition. Can you tell us when she will have to take warfarin during pregnancy? You know that
the
condition is
valvular
immunocompromised.
cardiac condition,
Yeah, metallic
metallic valves.
valves.
If she has metallic valves, yeah.
So you can hold that warfarin in the first 3 months, and then it can be started and continued till 36 week of pregnancy,
Weeks.
and then she can be commenced on low molecular weight heparin,
It
and
happened.
afterwards she can restart on warfarin, and she can continue breastfeeding. No effect on that. Then your case will not end here. They will ask you about
Future
this for the
pregnancy.
future pregnancy. So she can have a repeat episode of venous thromboembolism.
So she will be on this low molecular weight heparin in the next pregnancy, antenatally and postnatally 6 weeks. And if she has any family history, then we have to do her thrombophilia screening.
Yes.
And yeah,
Yeah, objective testing. Okay, that is
yes.
that she needs this
And we have
regular
to advise
checkup.
her for contraception as well. That we will not give her combined contraception.
Yes, because it will increase her risk. So any patient with any serious disorder, medical disorder, you should always comment on the type of contraception, and she should be counseled. Everything should be documented. She should be counseled on the risks and the benefits, and that's how you are going to close your case. So, any question they will ask you, it will be from the guidelines, okay? So you don't have to read any journals, just read the guidelines. And even if you remember the green top guidelines, you are good to go. Green top guideline and the nice guidelines. So that's going to be fine. For the long case, you don't have to read the patient information leaflets because here you are just recording story of the patient in her words. Okay, we are not going to change anything. We will just mention everything, whatever she is telling you, what has been done, what is pending, and present that history nicely in a cohesive way to the examiner, and then they can ask you about the findings on examination, and then we can uh, continue, and then they will ask you questions on VTE, or if they like, they can ask you about other things also. But usually
So we,
90%
yeah, yeah.
is on the same topic.
So we
So
don't have to explain to the patient that what is it, and we have to just talk to the examiner.
it's an important point. Since she is not your patient, so you are not going to give
Hmm.
her any instructions. Okay,
Okay,
that's not
okay.
allowed. So just you have to stay neutral. Whatever she is telling you, just write it down. Be honest. Present your history in a nice way to the examiner and tell them about the findings of examination, and then the management that patient has shared with you. you should write that down. Like I told you, write that down on the everything on the separate sheet so that you don't have to look or search for it. And then say that she has been uh, informed that she will be given this treatment, and then after so many days she will go for another treatment, or she's planned to go home after 3 days, 4 days, 5 days, whatever she will tell you. Okay, and she will be given outpatient follow-up. Okay, and then if the examiner asks you that what else you would like to do for this patient, you should say that you will give her patient information leaflet, sport groups, and so that if she has and a hospital contact number, because if she has any questions, any problems, she can contact you back. Okay, and then you should conclude by saying that this patient has been given appointment for follow-up in the OPD if she has been given. If she has not been given, so you can say that so far she has not been given any plan that she should where she should go for follow-up. So this is she's waiting for that.
So how we will come to know? We will ask the patient.
Yeah. You will ask her that so has your doctor informed you what do they plan? What are they thinking about your further management? Okay, so she will tell you that they have told me that I should come to the outpatient clinics, and then they will tell me that what should be done. So when I will leave hospital, I'm going to see my doctor after 4 weeks. You need to ask her this question, okay? Because if she has been there for some time, and now we are expecting that she will be discharged home, then we need to ask her this question also. So what have they told you? What are they planning? How they are planning about your further management? How they are planning to provide further care? So she will open up. She will tell you, okay? So you will mention that. If you forget to ask, then don't comment on that, okay? Like that. So as you know this case was not hard. VTE is a complicated case, right? Because questions can be very tricky, and Viva can be like hardcore Viva, can be difficult. So you need to revise your guideline. Only then you can answer their questions. So we cannot say that this is a general opinion, and we cannot give our opinion. We have to answer their questions in the light of evidence-based medicine. Okay, thank you very much. So that was the case, your case on venous thromboembolism. So I will see that who else is there. Okay, good morning, Dr.
Thank you,
Tay.
Dr.
Are you
Aisha.
there? Welcome. You did very well. So keep it up and practice more so that everything will come reflexly to your mind. Okay, you will not have to make any effort. It will just come to you. So thank you. And Dr. Tay, are you there?
Yes, I am.
Yeah, morning. How are you?
Good morning.
Okay, that's good. So as I said yesterday, now we are trying to practice with some long cases. So like we discussed yesterday, when we go for long case, they will tell you that in which hospital you are going. Have they informed you where are you going to take your exam? In Cork or in Dublin?
No, I was not informed yet.
Okay. I hope but you chose Dublin.
Yes.
Okay, so hopefully you will go to Rotunda National or Cumbre. So
Mm-hmm.
so these three hospitals, okay. So then, as you know, they will take you to the room of the patient. They will take your sticker. They will identify you. Then they will since usually two examiners are there, so they will take two stickers. But just give your stickers to them, and they can use them. Then they will take you to the room of the patient. And the
Okay.
recent change is that now whatever you will say or you will do, it will be observed by a clinical examiner who will be with you for 25 minutes. Unlike in the past, when the examiners they will leave you alone for 20 minutes with the patient, you used to take history, and then uh, you will do the needful targeted examination, and then the examiners will come and they will ask you certain questions. But now the examiner is going to sit there for full 25 minutes and going to see your communication skills and that your interaction with the patient, and then you will present your history examination findings, and then you will have a discussion on this. can be on the same topics mostly, but they can ask you about other subjects also. So when we talk about the inpatients, then today we are discussing the obstetric cases. So you can find a variety of patients. So you have to think that usually what type of patients do you get to see during your rounds. Someone, well, we have discussed a case where the lady had venous thromboembolism. Then for you, I've taken out this multiple pregnancy. So before you start taking history, you will have no idea that what case you are going to get and what is happening to her. PET is always there because for such patients, if it is uncontrolled, we are keeping them for optimizing their condition for treating them. Then in the second and the third trimester of pregnancy, threatened preterm labor or PPROM. These cases are always in the hospital, and rather they account for like 40% of the total obstetric admissions. Then you can get someone with who had this multiple pregnancy, she developed some complication, or she has been admitted for an elective cesarean section. Then unstable lie. So if your patient has an unstable lie, then she should be admitted to the hospital at 37 weeks of pregnancy. So again, they can give you this case. So these are the most common cases. Then maybe someone had GDM and her blood sugar level is very high, so we will admit her for controlling that. Then you can find a sickler who was admitted because she was in crisis, but now she has improved. So this sort of cases you are going to see in the obstetric population. So you will have to start from zero. You will go to the room of the patient, introduce yourself, then take a history, detailed history. You will take consent from the patient. I'm Dr. T. I'm here for my examination, and I'm supposed to take history of your illness, and then I need to examine you, and then I need some information that what management has been done so far. She will say, so can I start? She will say yes. You will say thank you. Then you will sit in a chair, and they will give you two A4 papers. On first paper, write down her history. On the back side of that paper, write down the findings of examination, because she will tell you something that I was examined and they found this thing, because you will be able to do only limited examination, okay? And then when you're taking history from the patient, she will tell you about management done so far, and she will know about the plan of management, what should be done next. So write that down on the separate page, okay, so that you will not be confused once the examiner starts asking you several questions. So now you have no idea, and you have come to the room of the patient, and you have just found during history that she is carrying a multiple pregnancy. So now you will take 2 minutes, then we will talk about her, that what questions should be on the history, and how you should present history to the examiner, and what examination you should carry out, and what investigations should be done. Then I will ask you a couple of questions on management of the twin pregnancy. So is that okay?
It's
Hello?
okay.
Yeah,
Okay.
that's fine. Okay, so
Yeah.
please take 2 minutes and just tell me that how you will carry out this case, how you will proceed. Your time starts now.
Okay.
This conference will now be recorded.
Can you start, please?
Okay. So I will go in and greet the patient and confirm her name and tell her that I'm here to take a history from her, and then do some physical examination, ask for the investigation that has been done for her and all the management that's been done for her, and have a little discussion with the examiner and ask her, is that okay with her? And then I'll proceed. Ask her what is her age, her gravida and parity, how many weeks was she at, and what they think scan, did she have an early booking for her pregnancy? And that if she's carrying twins, then I'll ask her whether it's a spontaneous conception or was it a IVF pregnancy or any assisted reproductive methods being used, and ask her how is her pregnancy so far. Um, is the fetal movement good, and has she suffered any complication during the pregnancy itself? Whether she's suffering from any signs of distended abdomen? Is she feeling very breathless? Any abnormalities? Then I'll ask for her past medical history, whether she has any underlying medical problem, whether she's been diagnosed with hypertension, diabetes before, any heart disease, and during this pregnancy, whether there was any specific illness that she's been diagnosed as well. And obstetric history, if this is not her first pregnancy, I'll ask how was her previous deliveries like and what are the outcomes of her previous pregnancy, and whether they were delivered normally or cesarean section, and whether she has any complicated labors before. And family history-wise, whether there's any twin pregnancy or multiple pregnancy in the family, whether it runs in the family itself, and any significant family history in terms of obstetric histories that's significant in the family. And I'll ask for social history. Does she know her BMI? Does she smoke or does she drink alcohol? What is her occupation? Who does she live with? Does she have enough social support at home? Who is going to take care of the 2 babies for her? Whether she's working or who is going to be living with her? And then I would proceed with examination in general. I'll see how is she doing. Is she talking in full sentences? Is she breathless? Is she having a very distended abdomen? Can she sit properly, comfortably, or is she lying down? How is her blood pressure? How's her pulse rate? Because she's carrying multiple pregnancies, so she has a higher chance of developing preeclampsia as well. So I would make sure that her blood pressure is normal. And then I would auscultate her lungs as well, just to make sure that her chest is clear, and I'll do an abdominal examination to see whether there's any signs of distended abdomen, to grossly dilated veins, and I would also listen to the fetal hearts for both fetus. And I would ask her, I would check for edema as well on her legs. And then I'll ask her what are the tests that has been done for her so far. Has she had any OGTT done? And did she have any serial growth scan done before? And assess her risk for VTEs as well. And as she's a high risk pregnancy, multiple pregnancy, she has increased chance of DVT as well. So I would assess her for DVT risk. And then ask for her growth chart as well if she had previous serial growth scan done. And then talk about delivery plan, depending on her gestation and what kind of twin is she, or whether there's any growth discrepancies in the babies. Then delivery would be planned based on whether it's a MCDA or DCDA, or whether there's any pregnancy complication. If the first twin is a cephalic presentation, then we would try and aim for normal vaginal delivery if everything is well. Otherwise, if the first twin is not a cephalic presentation, probably a cesarean section would be planned from 36 to 37 weeks. If it's MCDA and DCDA, probably 37 to 38 weeks. And if she requires cesarean section or any risk of preterm labor, then we may give her steroids just to cover for planned dose of steroid to cover for respiratory distress in the baby. And I'll talk to her about high-risk pregnancy with twins, and that she may require a slightly earlier delivery. She wouldn't be able to go full term to 40 weeks. We need to deliver her earlier, and that's why we have to give steroids to protect the baby's lungs and to reduce the risk of respiratory distress in the baby.
Yeah, that's great. So you have talked about everything, so, and about examination also. And one thing is there, you should always mention from where this patient was admitted, from the clinics or from the casualty, because if she is coming from A&E, it means that she developed some acute crisis, some complication. That's why she's there. So if you have a lady with twins, what is the most common presentation of any emergency situation? She will present when she's at the highest risk of having a preterm labor, right? Because of the over distended uterus. Okay, so that is the reason. So you have presented everything beautifully, and that's good. And you have taken a really a good and detailed history, which is very impressive. So just a quick recap, then we will go to the Viva questions. You will introduce yourself, and then you will say that, right, I have this patient, Mrs. So and so, who is like, let's say, 27 years old lady from Dublin, who is Gravida 2 para 1 at, let's say, 28 weeks of gestation, and she is in a dichorionic diamniotic pregnancy. And you will ask the same question, so that this is spontaneous or assisted production. If it is spontaneous, then maybe this is monochorionic, so you should ask her, because in cases of assisted reproduction, mostly they will be having dizygotic twins. So you should say that, did they tell you that babies have their own membranes, or they have separate membranes, or they have separate placentas? So she will tell you, and you will get some idea, and then you can comment on that, that this is a monochorionic or DCDA. Admitted with abnormal doctors and small for gestational age in twin 1 on recent ultrasound. It can be anything, okay? For here, I'm using this template because if there is discrepancy in the size by 20%, then you need to admit them for further investigation. Then what were her presenting complaints? So mention her presenting complaints, and sometimes the patients, they will go in a haphazard way, okay? So then it's your job to put that in chronological order, okay? Because that is helpful. So don't worry if you have written already, then you can put assign number 1, 2, and 3. And then you can say that she developed this first, then she had another complication, and after that, consequent to that, she developed this complication. Then you will give history of present illness. She was admitted when surveillance ultrasound showed absent and diastolic flow in twin 1. This is just a template, okay? Because maybe if you will get a case of twins, she will be having another problem. This scan was done in twin, and twin 1 was noted to be measuring small for the gestation age in routine antenatal clinic. So you can say, if she tells you categorically, then you can mention, or you can say that she doesn't have a good idea that what exactly was the difference. So you will indicate that what was the restriction, what was the problem, what was that. If you will ask her what was the abnormality on the doctor. So since they have been groomed for answering your questions, they have been prepared, so she can always tell you. But if you forget, no worries. Don't mention anything which you have actually not asked. Then you will say that daily CTGs have been done and they were uh, found to be normal. She reports good or reduced fetal movements and gives a history of SROM or bleed, or a vaginal bleed, and she has received 2 doses of steroids for fetal lung maturation, maybe some in cases of twins. You will find a patient who has received 2 courses of antenatal corticosteroids, so you are going to mention everything that that patient has told you. So in her case, she has different risk factors. What is her ethnicity? Because some medical disorders are more common in certain ethnic groups. She's a smoker, non-smoker with a history of hypertension, and she has a good nutritional status, or she's malnourished. She is, if you know about the BMI, this is her BMI. Her partner is also normal, healthy guy, and her previous pregnancies, since she delivered at term with normal or low birth weights. If she gives you, or if she has previous children, then mention those points and then say that she had a vaginal delivery. Then comment on the current pregnancy. This was a planned pregnancy or unplanned pregnancy. If this is a planned pregnancy, then was it assisted, and what she received for the treatment. Like she received this clomiphene citrate, or she was on GnRH. And she has been on folic acid. She saw her GP and booked for antenatal care at this many weeks. She had a dating scan done at so many weeks, and which revealed DCD, a twin pregnancy, and confirmed her estimated date of delivery by the first day of the last menstruation at, she will mention the date. Because all of these patients, they'll be knowing about their estimated date of delivery. Her antenatal course was uncomplicated to date with normal routine blood tests, and because you will ask her what testing was done on you and what were the results. And serology was normal. Her blood group is blood group.
حالة 3 برايمي 3 سي ام وحالة ال ار 64 سي ام وال ار 1 ولدت.
Right. Her blood is very important.
دي 6 to 4 دي ولدت خلاص ال ار و 4 6 ال ار 6 4.
Okay, so she was at very important to mention her blood group, important patient safety issue, especially if she is negative. We need to ask about any history of any bleed, and you need to tell her she will be receiving some shots called anti-D. She had an anomaly scan at 21 weeks which showed no abnormalities and an upper placenta, and Liker was found to be normal. Cardiac scans, they were normal, and we did OGTT at 28 weeks of gestation, and the result was found to be normal. So we are not doing this OGTT on each patient if she has certain risk factors. She attended antenatal appointments in the multiple birth clinic and had no previous admissions. If she has previous admissions, then it will change, of course. BP and urinalysis have always been normal, and serial growth scans were commenced at 26 weeks, and they have been normal previously. She has no background medical or surgical history of note, and no significant gynecological history. She had menarche at age 12, normal menstrual cycles, and cervical smears that have always been normal and up to date. She previously used the COCPs or Mirena or anything for that matter for how much time you should mention that. Then say this patient is on these medicines. You can mention them. Maybe she will be taking prenatal vitamins only. Maybe she's taking iron, folate because chances of anemia are 4 times higher in cases of twin pregnancy. Whenever you will mention some drugs, you should always mention any drug allergies. So you can say that she doesn't have any known drug allergies. Or if she has, you should mention that. Then ask about the obstetric history, previous pregnancies, any problems in the pregnancy with delivery or in the period after birth. What were the gestation ages at delivery and the dates if she remembers modes of delivery. And then you should say, I hope all the children are doing well. She will say yes or no. Okay. Then ask about her family history. If it is not significant, you can mention that. If it is significant, then you should mention that also. So if not significant, see, no family history of congenital anomalies or genetic syndromes. Then what is her occupation? Is she's a social smoker or a regular smoker? Then is she alcoholic or she is not? Is she on any sort of drugs? And she is living with her partner or she is living with her parents or she is living independently, and who is caring for the children if she has others. Then you can say, once you have completed your history, then you should say, so I can summarize the history for you that I have Mrs. So and so, who is a 27-year-old Caucasian or any other, this ethnicity, at 32 weeks gestation in her third pregnancy with dichorionic diamniotic twins, and she has been admitted for monitoring due to small for gestational age and absent and diastolic flow in twin 1. After that, you will say you have summarized the history. So for the patient, you can add at this point. So do you want to add anything? If you will say that, yeah, I forgot to mention that point, then you should add that one also. Okay. Then you will take permission from the patient and you will say that I need to examine you if you will allow me. And then you should say I will observe hand hygiene. So you can wash your hands if there is an attached bathroom, or if they let you take this sanitizer with you, then you can always use that. So, but make it a point to stand on the right side of the patient and ask her that did the staff check your BP this morning? She will say yes. So can you please recall what was the reading? She will tell you. If she tells you, okay. If she says that yeah, she did that and she told me that it is normal, then you should say that her BP was, according to her, her BP was normal this morning. She was afebrile. Okay. Then any testing was done because urinalysis is done on daily basis for almost all patients. They do that. And then ask her about her BMI and is she okay? Does she have any evidence of anemia like pallor in the palmar phases, in the eyes, and if she has any, you after testing her, then inspecting her, then you should ask her, look into her eyes, put your step on the left side to check for the heart sounds, say that heart sounds are normal, S1 plus S2 plus 0, auscultate the lung on the other side. Then go for the abdominal examination. What you will do, you will say first, let me have a look at your tummy, and I will maintain your dignity. If you will say that you can examine me, say thank you, and then first of all inspect it from the side. And then what are you going to notice? You will see that abdomen is distended, and is it consistent or inconsistent with the period of gestation? then you can see that there are obvious cutaneous signs of pregnancy like tinea nigra or striae gravidarum, and then you can take permission from the patient that can I just feel that how the baby is, how are things, and then if you will ask her that do you feel any pain when I move my hands on your tummy and look at her face, so she will say yes or no, and then take the symphysiofundal height to exclude fetal growth restriction. Okay. So as you know, it will always be larger than the gestation because of this twin pregnancy. Then you can tell her that I need to feel your uterus. Where is the fundus? Can you see the lie of the baby's side of the back? Can you trace two bags? Then if the abdomen is smoothly enlarged, so you can say that lighter seems fine. Presentation if you can find. Then engagement if it is a case of threatened preterm labor, so you can comment that this head is engaged or head is not engaged. So ask the patient, do you feel fetal movements? She will say yes or no. Okay. Then you should ask her, did they check the heartbeat of the baby in the morning? She will say yes. What time? 2 hours ago or an hour ago. So if they have not checked and you have time and you should have your stethoscope, so put the bell of the steth on the tummy to say and look or something. Then you should say that I can hear heart sounds of the first baby or second baby or both, as the case. But don't take too much long. Just auscultate for 15 to 20 seconds. Then examine her legs. Ask her to flex her legs, and then look for any charge, swelling, any redness, any edema, and then if you have a patient with PET, because PET, GDM, VTE always more common with twin pregnancy. So you will have your hammer. If you forgot to take your hammer, then just strike her knees with your, this stethoscope, the bell of stethoscope, and see that how she behaves. And then you will present the findings of history and examination to the examiner. So they will ask you what is your diagnosis. So you will mention then that what is your diagnosis, and then they will have a discussion with you. So they will ask you, so what is your diagnosis? So if the diagnosis is clear, you should say that diagnosis is clear, okay? That this is a case of twin pregnancy at this many weeks. And so this is a result of a spontaneous pregnancy or assisted reproduction. As you know, why we will have to mention that, because spontaneous conception, the risk profile will be different. And if she has an twins due to assisted reproduction, then the chances of complications are higher. So then they will ask you that what treatment she has received so far. So you will tell them that if she was admitted, she has received antenatal corticosteroids and she is on her prenatal vitamins, or if they have started tocolysis, then you can say that she is on that drug also. So then they will start this formal viva questions. Okay, so they will ask you what are important aspects of management of a twin pregnancy. So you should say that uh, she will have a normal pregnancy test. Then we should determine chorionicity, and it can be done best at 11 to 14 weeks. And if we have monochorionic diamniotic pregnancy, we will see a T sign. If this is dichorionic diamniotic, then we will see a lambda sign. That's how the membranes are attaching to the placenta. If we have monochorionic monoamniotic, we will not find any dividing membranes, and the fetuses and the cords can be intertwined. Then if they have different sexes, then it will be a dichorionic pregnancy. If they have if the babies have same sex, it can be a monochorionic or dichorionic pregnancy. Then if we talk about the general principles, then we know that the complication of the twin pregnancy is twin to twin transfusion syndrome. So we need to screen that. When you are going to commence scans for surveillance, you will start from 16 weeks. Why? Because 95% of the cases of twin pregnancy, they will develop during uh, up to 24th week of pregnancy. And after 24 weeks of pregnancy, the chances of having a twin to twin transfusion syndrome are just 1%. So twins are at higher risk of IUGR. So you will start these growth scans 4 weekly for dichorionic twins from 28 weeks of pregnancy till 36 week of pregnancy. So And these patients, we need to monitor for twin-to-twin transfusion syndrome in the monochorionic twins also. Iron should be given how much? 5 mg folic acid. Then comment on the anomaly scan, cardiac scans, and then she has received regular antenatal care, and how she's doing now. Did ever her BP rose? And then since the twins are at risk of preterm labor, so most of the, like 99% of the consultants, they give prophylactic antenatal corticosteroids. So if your patient has received, you should comment on that, that she has received one or two courses of antenatal corticosteroids. Then they can ask you about the modes of delivery. So you should remember the timings. A nice guideline is very helpful in in remembering these weeks and the time limits. So delivery in cases of trichorionic diamniotic, you should discuss at 36 weeks, and she can deliver between 36 to 38 weeks, but never beyond 38 weeks. Monochorionic diamniotic discussion will take place at 32 weeks, and she should deliver by 34 to 36 weeks. And if you have monochorionic monoamniotic pregnancy, when are you going to deliver them? At how many weeks of pregnancy?
32 weeks, 32 to
Yeah,
30.
you should be 100% sure 32 weeks, because there is a risk of interlocking of the this placental cord accidents and the chance of death of the fetus. So that's why you should deliver by 32 weeks. If you have triplets, because you can find triplets also, and these triplets, they would have admitted from 26 or 28 weeks of gestation. If it is an uncomplicated pregnancy, then you can carry that one to 35 weeks. So regarding mode of delivery, if the first baby is cephalic, you are going to offer a normal delivery. And you know, uh, cesarean section is usually done due to obstetric indications. So that's all you need to mention about the delivery. If they will ask any specific questions, you can answer that. You can tell them that for 40%, uh, the second in 40% cases of twin pregnancy, the second twin will be in non-cephalic presentation. So then 20% is the rate of cesarean section for the second twin, because it will change its presentation. So then they can ask you questions like this, that you have delivered first twin because it was cephalic. What will be your next action? So after delivering the first baby, you need to see what is the lie of the second baby, because it will change in like 40%. It will be non-cephalic. So how you should monitor? You should put two CTG probes, and you should recognize exactly where is the fetal heart. If you cannot locate them by just examination or by putting CTG, you should use ultrasound and then cite this CTG probes. So you need to inform the neonatologist, and because that we have a case of twin pregnancy, because you will need two baby doctors to see them. So first, when what happens during delivery of the twins is that first baby will deliver, then there will be a relative period of uterine inertia where she will have no contractions at all. Here you need to determine the lie of the second baby, and you can do it by just abdominal palpation, or better if you can use ultrasound scan. So if you think that the head can be moved, then under ultrasound guidance, you will guide head of the baby towards the pelvis. And since membranes will be intact, so don't do ARM until the head is fixed, it is engaged. Otherwise, there will be cord prolapse, and you will have to do cesarean section for the second baby. So cephalic presentation, just guided the head towards the pelvis, and this is a condition in the twin pregnancy in labor where you can start syntocinon infusion for augmentation, because patient will not have any contractions immediately after delivering the first baby. So even with intact membranes, you can start syntocinon infusion, and then you should try to get 3 to 4 contractions in 10 minutes. Once you have entered, push the head of the baby into the pelvis, then you can do controlled ARM. Ask someone to push the head of the baby against the maternal pelvic bone, and then do controlled ARM, and then you can deliver. And if the baby is like in transverse lie, you have the option of doing internal podalic version, and you need to do that through the intact membranes. If the baby is in breech presentation, you can do external cephalic version. So you should have the expertise available and then you can do that. So then, you should anticipate postpartum hemorrhage because there will be uterine atony because it was an overstretched uterus for a long period of time. So with delivery of the fetal head, fetal shoulders, you will give 10 units oxytocin IV. Normally in the low risk women, we are not citing any cannula, but in cases of twin pregnancy, you should introduce cannula for active management of the third stage of the labor because high chance of having a PPH. Give syntocinon and then give syntocinon infusion. It should run for 40 units of syntocinon in 500 cc normal saline or Hartmann solution, and it should run for 4 hours. So cords of the babies should be identified clearly by putting clamps or by putting this you can put this plastic cord clamps. Babies should be reviewed by the neonatologist. Okay, so and you should document everything in detail and provide care for the mother. Then they can ask you about the complications of twin pregnancy. So you should say more episodes of hyperemesis, more likely to get anemia, GDM, and then PET and VTE. So if we will talk about other issues. Maternal mortality is higher in cases of twin pregnancy, and chances of pregnancy loss in the first trimester are very high. Then in the mid trimester, your patient can have EPROM, card prolapse, high chance of APH, BPH, because the placenta if they have separate placenta or a common placenta, then maybe it will be lodged and anchored into the lower segment. Polyhydramnios, PET, intrauterine fetal death, stillbirth, cerebral palsy, and then fetal and the chromosomal abnormalities, and then structural abnormalities can be there. Then twin to twin transfusion syndrome and fetal growth restriction. When you will see this twin to twin transfusion syndrome, they will ask you how you are going to manage that. So let's say that this patient has been diagnosed to have twin to twin transfusion syndrome before 26 weeks of pregnancy. So what will you like to do for her?
Refer to
Laser.
fetal medicine specialist for laser ablation of the
Yeah.
vessels.
Yes. And if it occurs after 26 weeks of pregnancy, then what should be done for her? Then we don't have, yeah, we will not comment on this one.
Can
We
we
will
do
say that
embryo reduction?
you will say that you will refer to the fetal medicine because still there is no concrete evidence that laser ablation should be done or amnio reduction should be done. What should be done? Before 26 weeks, yes, we have concrete evidence that laser ablation should be done. But after that, we don't know. So it is up to the discretion of the attending consultant. So that's how you will close your case. And if they want to ask you questions, they can ask you different type of questions like um, what other complications can occur. So here we have mentioned almost all complications. And then what should be done after delivery? So you need to provide support to the mother because breastfeeding is good and we need to encourage her and we need to give her support because it's very hard to care for two babies simultaneously. Then community midwife should visit her on daily basis. And then if she needs charity, some help, then we need to put them in contact with some charities. Okay. And if she has like some other medical disorders, we need to optimize her health. So that's how you are going to close that. And then you need to give her a reliable and suitable form of contraception. Ask her what she has been using before, and then if that choice is still suitable for her, then you will recommend that to be used again, and you will document in her notes. So that's all we need to do in a case of twin pregnancy. So do you have any question, any problem? Okay.
This one, Anukrasha, OGTT we will be doing because twins is high risk pregnancy.
Yeah, twin is high risk, so we need to do that. Because why it is so? Because two placenta and they are producing more hormones, okay? Human placental lactogen. So that's why we more chance of having GDM or maybe uncontrolled blood sugar level. Then if she is having an IVF pregnancy, then as you know, chances of PET will be higher. And if she has conceived by donor eggs, then also the chance of PET will be high. Otherwise, also twin pregnancy has many complications. So if they will ask you what sort of pregnancy is this one, you should always say high risk pregnancy. So where she should go for antenatal booking, she should go to the consultant-led unit. Initially, this patient was also booked in the GP practice with the midwife, who referred to the midwife, and then on ultrasound scan, it was found that she has a twin pregnancy. So then she should be shifted to the consultant-led care. That is the point. Okay? Because their pregnancy, their labor, their postpartum period, she can have complication during any stage of her pregnancy and labor. Chance of cesarean section is also higher. So that's why she should go to the obstetric unit. So any question, any problem?
And twin delivery can be in the delivery room, or they are doing in the theater, or
Delivery room. In the delivery room. They are following very conservative practices. So which labor should be conducted in the OR? When you are not sure that this baby will come out with instrumental intervention, then you need to go for the then you're double-minded that she will deliver by OVD or she will not. Then you will take, or she needs rotational forceps. Then you will take that patient to the OR. Like if the presenting part is between +1 and +2, so or you need to give a traction of more than 45 degrees, then you should take the patients to the OR. Other cases, they are managed in the routine way. You need to inform the consultant, you need to inform the anesthetist, and you need to inform the pediatrician before you're delivering twins. If it is an elective delivery, then of course everything will be changed because everything will be organized. Okay? So, but for the normal pregnancy, like for the normal labor, you're conducting it in the delivery room. So these are all complications and this sort of questions they are going to ask you. So you will be knowing about them. So don't worry at all. Just you should be fully conversant. You should know what points are important in the history and you should follow a proper template. Like we discussed yesterday, we talked about the OB history taking and gynae history taking. So if you like, you can follow that template. If you like another template, you can follow that one, or you can just take a printout and you can add other points as you prefer. So I think we should have a break for 15 minutes and then we will continue doing the long cases.
okay.
Okay, same ID. So see you in 15 minutes. Thank you.